Have you ever read about it?
I'm not sure, sorry.
Okay, so this is a classical case, and I'm sure you might not have seen it in your clinical practice, but please remember that this is an exam case, and this is a case of a web, esophageal web, and this is known as a jet phenomena. I'll come back to you. Jet, as in aircraft jet. Now, this is a viva question, by the way. What are the associations of the web? And you make a note of this. Now, basically, what happens is that this is a condition in which there is, proliferation of the mucosa, and it just projects inside into the lumen, and there can be various shapes. So it can be, anterior, it can be lateral, it can be posterior, and this is what I am showing you. This is circumferential. The histological concept is that this mucosa, all layers are not involved. So the muscularis is not inside. And when there is circumferential web, then this is what can happen. And this becomes an exam case. And basically, there is a bit of upstream dilatation or hold up, and then contrast goes through a small area, and that is why we call it jet phenomenon. And these are two different examples. So this is an aunt mini case. Either you know it or you don't know it. You can see anteriorly there is a shelf-like filling defect. Remember these words: shelf-like filling defect. This is slightly, more advanced or a more prominent example of the same. Yes, please. This is your last case, candidate 9 and candidate 10. Please be ready after this. Over to candidate 9.
So this is a contrast swallow with the coned view of the hypopharynx. There's contrast outlining the vallecula and the piriform sinuses, and then there's this well circumscribed outpouching with the air fluid level in keeping with the pharyngeal pouch. I would have assessed a lateral projection to see whether
Excellent. So, confirm?
Yeah, Zenker's diverticulum.
Okay, I'll take over. Well done. So, you can mute yourself, and candidate 10, be ready. So, now pouches in the this is from your book. Have I unmuted you, candidate 10? Yes?
No.
No. Okay. Can you raise your hand again, please, candidate 10? I cannot see you. What is happening?
Yeah.
Yes, now I can see you.
I am. Yeah.
Okay. The case, I'm just teaching on this case, so I'll ask you the next case. Now, this is 7.3 in your book, pharyngeal and esophageal pouches. And Zenker's diverticulum is a diverticulum, which is what we saw in the previous case. Other than that, please also remember that a traction diverticulum has also come in the exam. Zenker's is favorite. In Zenker's diverticulum, what happens is that there is a point of weakness in between the inferior constrictor and the cricopharyngeus, and it projects laterally or posteriorly. But in the exam, they will show you unusual presentation of a Zenker's diverticulum. An unusual presentation, you have to, this is the exam take, beware. Unusual presentation on a plain film, a foreign body which is lodged in the Zenker's diverticulum, that has come in the exam, or a nasogastric tube which has gone inside and coiled up inside. So if you see this CT from the literature, you will be scared, oh my God, what's happening? Is there an abscess there, and things like that. So stretch of imagination. So beware of Zenker's. This is a case from stat dx, where there is a large Zenkers which is sitting in the superior mediastinum, and on a barium it looks like this. So beware of plain film, particularly. They have shown many a times in which there is, they might show you a lateral. If you see this, they might show you a lateral plain film where there will be bubbles and things like that. Here you will be worried, oh, there is an abscess, and they will say the patient is fine, and that is Zenkers. Number two, same film, but with a foreign body sitting inside, a plain film. So beware of Zenkers. Traction diverticulum, again, etiology is different. Traction means that there might be lymph nodes which will pull the part of the esophagus towards it, and it gives you a classical appearance. Usually there might be, so beware of traction diverticulum for the exam. Epiphrenic diverticulum can also be because of what we call pulsion diverticulum because of motility disorders. So this is the list in your exam, but I just wanted to show you the exam cases which have come or can come. Okay, Aunt Mini case for what we call pattern recognition. Just give me the pattern. How will you describe this, Ben? Over to you, please.
Sure. This contrast solo study of the esophagus, we are at the level of the lower esophagus. We have got some linear opacifications at the distal esophagus near the gastroesophageal junction.
So look at this mucosa. Normal or abnormal?
Abnormal.
And how? I'm trying to hear the words. How will you describe it?
So linear lucency. There's no pseudo. I'm thinking of pseudo diverticular, but at the side wall, I do not see any abnormal outpouching.
Very good. So this pattern, classical description will be that it gives you a coarse or a fine granular pattern. Remember those words. You see, usually the esophagus is quite, it is a very smooth, and then you see this coarse granular pattern. And this is a differential diagnosis where it is a huge list of, inflammatory, infective, etc. Because of time factor, I'm just skipping points, but I want you to develop your eyes on this. And once you pick it up, then the examiner is going to ask you differential. And then this is the differential. So the idea was just to develop your eyes on this finding. Okay, spot number 10. What is this?
Nutcracker esophagus.
Nutcracker or corkscrew.
Corkscrew.
Right. So corkscrew is tertiary contractions, and this is a motility disorder. It's an Aunt Mini, nothing else. It should be confused. Tertiary contractions of the esophagus. And here is a mix-up of two things which I just showed you. This patient has got a motility disorder, so tertiary contraction, and with that, pulsion diverticulum. So pulsion diverticulum are associated with motility disorders. Yes, please. Describe this stricture.
So there is a focus stricture in the mid esophagus with smooth margin, and there is distally we have resumption of normal caliber esophagus.
Pertinent negatives. Your description was very good, but I want you to add your pertinent negatives.
So there's lack of shadowing, shouldering.
Excellent. Well done. So when you describe a stricture in the bowel, these words should be pertinent, negative, or positive. When you are describing it as you have described that this is a smooth stricture, and normal mucosa, there is no shouldering, should be your pertinent negatives, no mucosal destruction. So now, can I ask you this appearance? Is it for a benign stricture or a malignant stricture?
benign.
Irony is that esophagus, remember it like this, does not follow this principle. And look at the differential diagnosis here. Esophageal strictures smooth, and you are absolutely right that there are many things in the smooth world which can cause, smooth strictures. But irony is that malignant lesions can also cause smooth. So we are not very good. I remember it like this, that if you find a frank malignant stricture in the esophagus, like mucosal destruction, shouldering, etc., you are very confident that this is malignant. When you find a smooth stricture, you should still keep what we call malignancy in the differential. And I have seen quite a few, and particularly which are coming from outsides, something sitting in the mediastinum, small cell carcinoma and things like that, and secondary invasion of the esophagus. Having said that, classically in the exam, they will show you cases in which, there will be benign etiology. One thing which I want you to remember is scleroderma. Now, scleroderma is an extremely important exam case. It can come as a long case. It can come in so many different, films. Scleroderma involves whole of the bowel, so they can show you, esophagus or a small bowel or large bowel. I'll show you later on. Point to remember is that esophagus is the most common site of involvement of scleroderma. Remember that. And irony is the films which come in the exam are mostly of large bowel or small bowel, because the findings there are more specific there. Now, another thing which I want you to concentrate from this book is, because this will save you something in the exam. Neoplastic submucosal and extrinsic masses. What does it tell you? Extrinsic masses is the type of mass which I was telling you, mediastinal tumors. So even malignant tumors can cause smooth stricture. But I want you to concentrate on something else. These words you have to remember, but these will be key for your differential diagnosis. And the classical case, how will you describe it, candidate 10?
So there's an area of indentations in the, presumably this is a lateral projection that would be posterior wall of the esophagus. If it's AP view, this will be a lateral wall.
So, so just concentrate on your description. So, what is happening?
So, and the indentations is implying there is an extrinsic compressions on the esophagus.
Okay, debate.
So
excuse me, debate. The debate is, you have said extrinsic impression. I will take it. I will not disregard it. But the debate is, can it be sitting within the wall and projecting into the lumen? What about this idea?
Because the contrast is still coating the esophageal wall.
So the hypothesis is that something is sitting within the wall, and then it is, projecting into the lumen and giving you this kind of appearance. What about, do you see this idea?
Okay.
So you see, this thing is, you are absolutely right. When you are looking through the lumen, you cannot make out if it is coming from outside or is it within the wall. And I will teach you how to discriminate between the two when we will cover barium in the stomach, and particularly large bowel, which is important in the exam. Having said that, we are not very good in contrast rays. Is it Intramural versus extramural means extraneous. So now, debate point is how, as an examiner, I am going to ask you the differential diagnosis. Okay, I take your point, it might be sitting outside. Now, if it is sitting outside, means it is coming from the mediastinum. Do you see anything there, any soft tissue there?
No.
No. So, there is nothing big sitting. So it must be in the wall. Now, give me the differential diagnosis of this.
So we have so given the smooth margin, and we can see there's no erosions of the mucosal wall. So I'm going more of the benign etiology like a leiomyoma.
Excellent. Excellent. Now I will take over because of time factor. Well done. So if you see here, this differential will save the day for you. Read it carefully. 7.6. One of the subheadings is that this is the whole, inflammatory, neoplastic, submucosal, and submucosal. So I was going into this territory. Submucosal lesions and extrinsic masses. So submucosal lesions, leiomyoma. And your book tells you that this is the most common due to smooth eccentric submucosal mass. Calcification is highly suggestive, and it can be multiple also. Now, rare lesions, there are many words here, rare reasons, which can be a lipoma, it can be nerve sheath tumor, hemangioma, glomus tumor, solitary fibrous tumor, etc., etc. Read that. GIST is extremely important. Now, GIST is a favorite tumor for the exam. I will show you in the stomach, etc., where it is, more specific. But remember this, esophagus is the least common location of GIST. So GIST can happen anywhere in the GIT, right? But it is least common in the esophagus and much less common than the leiomyoma. And so this is an important point to remember, though it can happen. GIST can also happen outside the GIT, in the mesentery and things like that. Many organs have been reported in literature. We'll come back to GIST later on. Next time. Okay, thank you. One more film for candidate 10 and then candidate 11, be ready please. This is your last film, candidate 10. Over to you. This is an Aunt Minnie case, just give me the diagnosis.
Esophageal varices.
Excellent. So this is varices of the esophagus. You get this serpentinous filling defect, and this is how it looks like. And remember one thing, that cirrhosis will cause varices which are going from down to up. And when there is superior vena cava obstruction, as in mediastinal tumors, etc., there can be varices which can come from up to down. So these are esophageal varices, and looks like snake anaconda sitting inside the human hair. And this is another example. Candidate 11, are you with us? If you are, please raise your hand. So I have unmuted you. And candidate 1, be ready for next, maybe I'll give you a one-odd film before we finish. So candidate 11, over to you. Sorry, I have not unmuted you. Just bear with me.
Hi.
Hello, candidate 11. Can you please tackle this? Just X-ray.
Yes.
I'm not worried about here. Look at the mediastinum. What's happening in the mediastinum?
So this is the frontal chest X-ray of a skeletally mature patient. What I can see is there seems to be an elongated soft tissue mass starting from the right superior mediastinum along the right paracardic border. It also appears to be involving the left side of the mediastinum and along the hard border. So this seems to be a dilated viscus in the mediastinum. My prime differential would be that this is a dilated esophagus, probably eclasia.
Excellent, well done. So what are you going to do next?
I would like to do a contrast swallow.
Okay, well done. If you see this film, what is happening, and this is, eclasia is a very important film in the exam favorite, and they will always show you on a chest x-ray subtle signs. And you have to look this linear shadow here, which causes a double sort of a shadow of the mediastinum, boundary of the mediastinum. If you look carefully, there is a bit of dilatation here. Of course, right now we are doing esophagus, and you are so confident about it being a eclasia, but in the real world, always keep it in your mind. So well done. Now, the correct answer is yes, you will do a solo. And these are various examples where you can see, this is not the same case, this is a different case. You can see this red tail appearance here, and then dilatation, eclasia, cardia. Okay, sudden chest pain after bout of coughing. What is your finding?
Okay, so this is frontal chest x-ray of a skeletally mature patient with history of sudden chest pain after bout of coughing. I can see that there is a subcutaneous emphysema on either side of the neck. I can see that there is a subtle lucency outlining the aortic knuckle as well
Excellent.
as the...
So conclusion, well done. So what is the conclusion?
This is pneumomediastinum secondary to oesophageal tear or Burhaft syndrome.
So what will you do?
I will do a CT or a contrast swallow. CT with contrast, sorry.
CT is fine, good answer. And sometimes what happens is that we have to do a solo examination. What happens on a CT that at times anatomy is not known. You know, history is, this is a horrendous condition. I've seen quite a few. Where I work is a cardiothoracic center. We work in a cardiothoracic center, so I've seen quite a few of them, and particularly on call. And this is a horrendous condition where a patient is absolutely fine and then has a bout of coughing and with this tear. So clinical history is very suggestive. CT is the correct answer. In the real world also you do a CT scan. But many a times the surgeons, they want a bit of anatomy, you know, where is the, can you please outline where the tear is, upper or middle or whatever. So the point is, a viva question is, which I'll ask you, number 11, what kind of contrast will you use?
I would use a low osmolality contrast medium.
Excellent. So that's the correct answer. Well done. Where is this foreign body?
This is in the esophagus because I can see the round projection in the AP film.
Right. Take home point that X-ray, on a chest X-ray, a coin or a flat object orients in a coronal plane if it is in the esophagus. So that is pathognomic of a foreign body in the esophagus. Yes, please. Over to you. Can you describe this?
Right. These are spot films from contrast swallow in a 70-year-old patient with dysphagia. What I can see is there is a long segment of narrowing of the esophagus with mucosal irregularity. There is shouldering, and which makes it very worrisome for aggressive lesion, a malignancy.
What are you going to? Well done. I'm stopping you because of time factor. What will you do next?
CT scan.
How will a CT scan help you?
It will outline the oesophageal lesion better. Otherwise, we can. Sorry.
Then what will happen?
It will go for endoscopy.
Here you are. You see, the correct answer is an endoscopy. Please remember. And this is something which I have observed many a times in the 2B exam. Classical question, what will you do next? and people jump to next imaging modality, in particularly in GIT. You have to have a tissue, and in the real world also, this is exactly the scheme of things. When you have picked up that there is a tumor on let's say this thing, you have to ask for, first of all, an endoscopy and a biopsy. Once the the biopsy comes, and you can ask for in tandem also. But having said that, the first idea here was that the strictures or irregular strictures, interestingly, in the esophagus, as I've told you, that benign strictures can have malignant causes. Irregular strictures can also have benign causes. So remember that esophagus is slightly tricky in this way. Now, suppose biopsy came out as a malignancy, it was an esophageal carcinoma. So, number 11, question to you. How will you stage this?
It can be staged by endoscopic ultrasound for the T staging and CT chest to look for distant metastases.
Okay, very good, well done. Now, if you see here, number 11,
yes.
Okay, I'll give you, okay, please continue with us. I'll go into a bit of a teaching mode here.
Sure.
Now, these are key questions. A few of the tumors in GIT I am going to teach you, and many of them I am not going to teach you. Esophageal carcinoma is one of them which you should have some concepts for the 2B exam. Beyond 2B is a different world. I always divide it like this. So for 2B, I will teach you carcinoma esophagus up to extent. Now, first of all, key exam questions is that how are you going to stage it? Your answer was absolutely perfect. That for local staging, you will do a CT scan, and for a T, you go back to the basic T and M staging. So the best modality for T staging is an endoscopic ultrasound. Sometimes you cannot do it because the lumen is very tight, etc. That's a different word. Otherwise, you do a CT chest, abdomen, and pelvis, and you do an endoscopic ultrasound. With that, we also do a PET scan. Now, why a PET? In UK, we don't use PET scan the way people in USA use it. They do it for each and everything. There are a bit financial reasons also involved. But in esophageal carcinoma, the lymph nodes are extremely important, and this is an exam type of a concept. Please remember, in a lung carcinoma also, lymph nodes are so important that if a lymph node crosses to the mediastinum, in the mediastinum to the contralateral side, it completely changes the staging and prognosis in a lung carcinoma. So PET scan is absolutely critical. Similarly, in an esophageal carcinoma, there is a concept of local nodes versus non-local or distant nodes. The concept is that local nodes are, end stage, but if they are not local, then we call them metastasis. That is the concept. Let me give you an example. For example, there is a tumor sitting at the gastroesophageal junction, and there are gastric lymph nodes. These will be known as local nodes. On the other hand, there are nodes sitting at the level of arch of aorta. These are non-local. These are metastasis. Similarly, if there are nodes sitting in the retroperitoneum, becomes metastasis. So for that, PET scan is done as a routine. So the answer is for T and M, T staging, CT, and M also CT, and endoscopic ultrasound for T staging, PET for particularly for lymph nodes. Now, these are the rates, and at times you do a new adjuvant chemotherapy. Nobody is going to ask you. This is just for your knowledge. And combined CT and ultrasound, EUS has got quite a good 86% accuracy.